Yes, thank you very much for that introduction. Yes, I am Dr. Patricia Murphy. I have been a cardiologist here in Westwood, New Jersey since 1995. I'm a non-invasive cardiologist, meaning I do the medical care of heart disease patients. I'm not a surgeon. I don't do operations or angiograms or any of the procedures, but I do consultative cardiology both in my office and in the Valley Hospital. So today's topic is broken heart syndrome. And in the next couple of minutes, we're going to review what that is, how to make the diagnosis, and go over a little bit about the treatment. So first, a definition. So what is broken heart syndrome? So the term broken heart is the lay term that describes this condition, which is triggered by intense physical or emotional stress, such as a sudden medical illness, the death of a loved one, or an argument. But it can occur without a clear triggering event. The most common symptoms are sudden chest pain, trouble breathing, and even fainting. The condition itself is typically temporary and occurs most often in older women. And in fact, in various studies, 80 to 100% of cases are in women, and the average age is 61 to 76 years. The medical term for this condition is stress cardiomyopathy, and the word cardiomyopathy has three parts: cardio, heart, myomuscle, pathy, disease. So it is a heart muscle disease caused by a stressful scenario. It is also called Takotsubo cardiomyopathy, and it was initially described in Japan in 1990, and the name was given based on the appearance of the heart on various types of imaging, and they named it after a Japanese octopus trap. So here we have a Takotsubo with an unfortunate octopus. So the concept here about the Takotsubo is that it is a vessel with a narrow neck and a large body, and the octopus enters it head first and then can't navigate its way out. So here we see an example of a Takotsubo with images produced by X-rays. So the picture on the right is the Takotsubo sitting like a vase with its base on the table and the narrow neck up top. And the picture on the left positions it the way the heart is positioned in the chest. So typically the diaphragm is down here below. The heart sits on the diaphragm like this, and then there's the lung tissue in the background. So this is what we'll see later in some of the pictures. But again, a narrow neck and a large body. So what happens to the heart with Takotsubo broken heart or stress cardiomyopathy syndrome? So first, the left ventricle, which is the heart's main pumping chamber. And again, the heart is a pump, pumping blood and circulating it around the body. The left ventricle stops working properly. And in most cases, the area of abnormality is what's called the apex of the heart. The apex is like the tip of a triangle, and the tip of the heart is called the apex. And these pictures here that we see, the one in panel A is something called a ventriculogram, and panel B is our now familiar Takotsubo. So this angiogram is performed, it's called an invasive cardiac study. In this particular case, a catheter is threaded up through the leg, up around the aorta, and down into the left ventricle, and then contrast dye is injected, producing this picture. And the white arrows here show the base of the heart, which is narrow and contracting normally. So this part of the heart is pumping well. And then we see this apical ballooning. We see this abnormality where this whole area isn't moving or pumping properly with each heartbeat. And again, it's similar to our Takotsubo image. So it's called apical ballooning. The apex of the heart enlarges and stops moving properly, and that's the medical term. Other areas of the heart can be affected in Takotsubo, but this is the most commonly described pattern, and it is the original one, which is where the name was derived from, this Takotsubo. So how is Takotsubo different from a heart attack? So although the symptoms are similar, chest pain, shortness of breath, dizziness, sweatiness, various symptoms, stress cardiomyopathy is caused by a different process in the body than a heart attack, which the medical term for heart attack is myocardial infarction. Myo, muscle, cardial, heart muscle. And infarction is the term for the death of tissue. So in a heart attack, a heart blood vessel suddenly becomes blocked, typically with a blood clot, which forms inside of the blood vessel. And so what happens is we have a plaque, which is a cholesterol fat buildup in the lining of the artery, and that plaque has a cap or a cover. And suddenly that cap becomes either ruptured or ulcerated, which exposes the fat in the lining of the artery to the blood that is flowing through. And then a blood clot forms right there and then, blocking the flow of blood to the heart muscle. That leads to heart muscle damage and weakens the heart pumping function. When a person having a heart attack goes to the hospital and is treated, the goal of treatment is to restore the blood flow to minimize any damage and hopefully preserve the heart pumping function. But people with stress cardiomyopathy typically do not have disease of the large heart blood vessels. So even though they have an injury of a portion of the heart muscle, like a person having a heart attack, the mechanism of that injury is different. And the possible causes for stress cardiomyopathy include stress hormones like adrenaline, small blood vessel dysfunction, poor blood flow through the little tiny blood vessels that supply blood, and even spasm of the heart arteries. But really the most studied and the most common contributor are these stress hormones. And that's how we get that broken heart syndrome, stress cardiomyopathy description. So people often ask, is this heart injury permanent? And fortunately, stress cardiomyopathy is typically temporary. And people usually get better within 1 to 4 weeks of the diagnosis. But during that period of time, while a person is affected by stress cardiomyopathy, serious heart problems can arise, as listed here. So congestive heart failure is a condition in which the heart does not pump normally. And so the heart can not allow the blood to flow forward, which can cause low blood pressure and problems with all of the organs that require blood to function. And then also in congestive heart failure, sometimes the blood entering the heart is backed up almost like a traffic jam and backs up into the lungs or other organs, which can cause other difficulties. And if severe heart muscle dysfunction occurs, a person can develop what's called cardiogenic shock, meaning low blood pressure and low blood flow to the organs, often associated with confusion and difficulty breathing. So even though the stress cardiomyopathy is typically temporary, you can develop congestive heart failure and cardiogenic shock from this condition while you're waiting for it to improve. Heart rhythm problems can occur when a heart muscle is severely reduced in function. It is more susceptible to electrical abnormalities, such as ventricular tachycardia, which is a fast heartbeat from that ventricle, that pumping chamber, that can, if not treated, result in death. And this condition can also be associated with heart valve problems like leaky valves as a result of the change in shape of the ventricle, the pumping chamber, when this condition sets in. The other potential complication is blood clot formation inside of the heart as opposed to inside of the blood vessel with a heart attack. And those blood clots, if they form inside of the heart, can travel to other areas of the body. And the medical term for that is embolism. And the blood clot traveling can cause complications such as a stroke. So, what tests are necessary to make the diagnosis? So first and foremost, you need to have a history and a physical exam performed by a health professional who will order additional testing to determine what's going on. So one of the first things that are done is a blood test called a troponin, which is a protein that's released into the bloodstream when the heart muscle is injured. So troponin elevation can occur with several conditions, including stress cardiomyopathy and myocardial infarctions or heart attacks. So an elevated troponin in and of itself does not differentiate between these two things, and we need more information. Another test that's often done is a chest X-ray, and that will help check for fluid in the lungs, which is one of the signs of congestive heart failure. Heart enlargement can be seen on an X-ray, looking like that Takotsubo, and other causes of chest pain need to be evaluated, such as collapsed lungs. So a chest X-ray gives us information about all of that and helps us in our detective work to try and come up with the diagnosis. Another test that's often done is an electrocardiogram, sometimes called an ECG or EKG, which checks the electrical activity of the heart for evidence of injury and electrical rhythm problems. So here we see what's called a 12-lead ECG. And the 12 leads here are leads 1, 2, 3, AVR, AVL, AVF. These are what are called the limb leads. And these tracings are obtained from stickers that are placed on the arms and legs, the limb leads. Then these other 6, V1 through V6, are called precordial leads. And those are from stickers placed on the chest wall. And all 12 of them are placed in this configuration, which tell us a great deal about the heart. So this particular person is in normal rhythm. So each heartbeat has a P wave, a QRS, and a T wave. So we've got nice normal rhythm. All of the beats are evenly spaced as we go across. And the abnormality, the biggest abnormality we see here are on the chest leads or the precordial leads. And we're looking at what's called the ST segment. And these ST segments are elevated. And so this EKG, ECG, suggests injury to the front wall of the heart. And once again, you can't tell the difference based on this tracing between a heart attack or myocardial infarction and stress cardiomyopathy. The electrocardiogram can look the same. So far we have the troponin elevation, we have the electrocardiogram that is consistent with injury, and we need to continue to look to see and make the difference, make the diagnosis to determine the difference between a heart attack and the stress cardiomyopathy. So one of the next tests we frequently do is an echocardiogram, which is a heart ultrasound. It's a sound wave test that creates a picture of the heart as it beats. This picture here is a still frame from an echocardiogram, and it shows the left ventricle. So as opposed to the previous pictures we saw, this one shows the left ventricle sort of upside down. Oops, sorry about that. So, so this is the neck, the narrow neck, and this is the apical ballooning. So we see a typical pattern looking like our Takotsubo on this echocardiogram, and it would be unusual for a heart attack patient to have an echo appearance like this. So this echo test is pushing us more toward the diagnosis of Takotsubo cardiomyopathy, stress cardiomyopathy, broken heart syndrome. So the base of the heart working well, the apex of the heart ballooning out. So the next test that we often do is called a cardiac catheterization or angiogram. A catheter is the tube and the term angiogram are the pictures. Angiogram, blood vessel, picture. And when we do a cardiac catheterization, a thin tube is placed into the heart, either through the leg or the arm, and pictures are taken of the heart blood vessels looking for clots or blockages. And this is where we make a more definitive differential between the stress cardiomyopathy and the heart attack. Typically, you'll see a blockage in a heart artery with a heart attack and no blockages in heart arteries with a stress cardiomyopathy. So the picture on the left is a picture from an angiogram. The catheter or tube comes up from the leg. In this particular case, is threaded up around the aortic arch, we call it, into the right coronary artery. And then dye or contrast is injected through the tube into the artery itself, creating this picture. And the picture on the right is a representation of what this right coronary artery looks like. And this is a normal coronary artery. This is one of the three main heart arteries, the other two being the left anterior descending and the left circumflex. But when you do a catheterization in a patient with stress cardiomyopathy, the arteries all look normal. We don't see any blood clots or blockages like we would if a person was having a heart attack. So next, now that we've made the diagnosis, we move to treatment. And so the treatment for stress cardiomyopathy is medications. There is a difference between a heart attack where you open an artery to restore blood flow and the treatment of this cardiomyopathy, which is medical. So depending on the symptoms and the heart muscle function at the time of diagnosis, that will determine what sort of a medical regimen is prescribed to a patient. So examples of medicines that could be used are diuretics, which are medications that help remove fluid from the body. Those can be given either through an intravenous or in pill form. ACE inhibitors, which are medicines that relax the blood vessels, making it easier for the heart to pump and recover from this condition. They lower blood pressure also, and they alter the hormones that are involved in this condition as well. Next, we have beta blockers, which are medications that blunt the effect of adrenaline or the sympathetic nervous system on the body, which is a main driver causing this condition, and blocking the effect of the sympathetic nervous system is critical in helping to treat the condition. Sometimes we also need to use anticoagulants, which are blood thinners. For example, if we discovered a clot within the heart chamber, blood thinners are given to reduce the risk of an embolism, which is a clot traveling. Importantly, the blood thinners do not dissolve the clot. They prevent it from enlarging, which is the body's natural response to a clot, is to make it bigger because clots are supposed to help us not bleed. But when clots occur where they do not belong, we need to let the body's other mechanism, which chews up the blood clots, to work and slowly but surely dissolve the clot. So the blood thinners don't dissolve the clot. They prevent it from enlarging and allow the body to proceed with healing and removing the blood clot in the location where it does not belong. Medical treatment is often given for a short period of time until the condition improves. 1 to 4 weeks is the general time course for recovery for this condition. But some people do need to take the medication for life, particularly if their heart muscle function does not normalize after treatment. That's not the usual, but it is absolutely possible and described, in which case continued medical treatment is recommended. Again, the typical duration of medical therapy is at least 4 weeks. And usually an echocardiogram, that heart ultrasound, is repeated after a period of recovery to see if the heart muscle function has returned to normal. One important fact is that it is possible to have stress cardiomyopathy more than once in a person's life. I have seen people have it 2 and even 3 times under stressful medical situations, under stressful personal situations. So sometimes people are kept on beta blocker medicine to chronically blunt the effect of the sympathetic nervous system or adrenaline on the body, to reduce the risk that the stress cardiomyopathy will return. So that is my presentation. Thank you for listening, and I'm ready to take questions.
Well, thank you so much, Dr. Murphy. It's very interesting, and I wonder, I'm sure this has been an occurrence and it's been going on for a long time, but I'm wondering, with the kind of new, how can I say, the mind-body connection becoming a more popular thing in medicine, is this something that has been more researched in recent years? Is the broken heart syndrome, is it a fairly new issue, and are they looking more into it, I guess is the way my question.
That's a great question. So the initial description of the condition was in 1990. So it is relatively recently described. And there's no two ways about it. There is a contribution of stress and emotion to this condition. But not everybody who has something terrible happen to them will develop this condition. And it's likely there's some degree of genetic predisposition. You know, the fact that it's mainly in women is important, but the women who typically experience this are postmenopausal. So it's unlikely that estrogen and such are directly involved. But when you're treating a person who has been through this, it is important, in addition to treating medically and following up medically, it's important to counsel them the importance of how to manage their stress. I always say to people, you can't change the world, but you can work on how you respond to the stresses that you have in everyday life. And people who don't learn how to sort of calm themselves down or soothe themselves in some way are more susceptible to having this happen to them again. So whether it's breathing techniques or meditation or listening to music or some sort of a technique that a person can teach themselves to recognize when they're stressed and to learn to relax is an important part of the treatment. And in particular, yoga breathing has been studied in terms of it's a powerful tool. It lowers blood pressure, lowers heart rate. It's been clinically proven to work, and you always have your breathing with you. It's just a matter of recognizing that things are becoming stressful and using your tools to help get better.
That's excellent. And I love what you just said, because as we talk about the whole mind-body connection, it's important too to, of course, recognize what you can do medically, but like you said, to take care of yourself emotionally and mentally is equally as important, you know, which we don't always tend to do. So very critical. I love the yoga breathing. A couple other questions. Somebody's asked, how frequently is death immediate? I don't know if that makes sense.
It's relatively rare. You know,
Relatively rare.
Usually people do well with this condition, even if their heart is severely impaired. The sudden death would typically occur as a result of electrical instability. So the weaker the heart muscle is, the more electrically irritable it is, and the more likely to have these what are called malignant arrhythmias or abnormal heart rhythms arising in that sick bottom chamber. When a person is in the hospital, they are typically on a cardiac monitor so that a quick diagnosis and intervention can be made. And in certain situations, sometimes people can even go home with a wearable life vest, it's called cardiac monitor, if their muscle is severely reduced and they've had some electrical instability or irritability in the hospital. There are devices that can be sent out, as opposed to a more permanent defibrillator implanted in someone who has a more permanent condition. The hope is that within a week or 4, that this will resolve, the heart muscle will improve, and the tendency to these dangerous electrical rhythms will resolve.
Okay. Is there a genetic disposition?
That's a great question. I have not seen, I mean, I've seen this condition many times in my 30 years of practice, but well, although it wasn't diagnosed until I was somewhat far along in my practice, in terms of description in 1990, the issue is that there isn't right now a genetic test, and I haven't seen multiple family members experience it, but that's not to say that it isn't possible. Again, we know that women have it more than men, and older women have it more frequently as well. And there is some ongoing research to try and tease out more of a predictive model who this might happen to.
Well, I know you mentioned something. Can any proactive medication be given? Maybe in, I don't know, to prepare for, like if you notice a patient who's had a significant loss or event, I imagine.
Yeah, that's a great question. And there is not a current recommendation for such a thing. But these beta blockers have been around for a long time, this class of medicine. They used to be given very frequently as first-line therapy for high blood pressure. They're not given as often now because they are less effective in blood pressure lowering than other agents that we have. They are often used if a patient tolerates them after a heart attack, because they do reduce the effect of these sympathetic hormones, these stress hormones on the heart, which is part of what causes or is associated with the dysfunction. So, but to say we're going to put someone on a beta blocker to help prevent broken heart syndrome, there's no evidence for that, except if someone's experienced it before. Sometimes we will continue it over the long term, depending on the person, to try and hopefully prevent an episode from happening again. If someone is under, for example, ongoing stress or has ongoing severe medical illnesses, the medication is sometimes continued to try and reduce that risk.
Okay, thank you. To your knowledge, again, I know the research is limited, but most people who experience this develop later complications, to your knowledge?
Most people do not. Most people recover completely. There is always that risk of having it come back again under another stressful situation, but most people within 1 to 4 weeks, even the ones with the most severe abnormality in their heart muscle function, they recover, but you have to, of course, keep them safe and well during that period of time, which does carry its risks, as we talked about before.
Okay. Is it normal during this syndrome to also have pulmonary pressure high? So
when we do these echo tests, we do more than just take a picture of the left ventricle. We take a picture of all the different heart chambers, and there is one measurement we make of pulmonary blood pressure based on the speed of blood flowing through the right side of the heart. Not everybody who has this stress cardiomyopathy will develop high blood pressure in the lungs. It can happen if someone has severe heart muscle dysfunction, or if a heart valve becomes dysfunctional. And sometimes if people have some baseline elevation, it can worsen, but it's not one of the most commonly seen problems associated with this condition.
A couple more questions. And again, I know the research is maybe somewhat limited, but is this condition, to your knowledge, more common in one ethnic group or another, or over another?
That I haven't seen in my reading. Women for sure, but an ethnic predisposition I'm not aware of.
Okay. And just one more question. The broken heart, a broken heart syndrome attack, do you know if it happens more often in the cold weather of winter? And if you have any idea if it's brought on by shoveling snow?
That is an excellent question. So I do not know about whether specific to this, but cold air can can be associated with a higher risk of spasm of heart arteries, which can cause problems. And there are there are respiratory issues that are associated with breathing cold air that can sometimes place stress on other organs, such as the heart. Snow shoveling in particular is commonly associated, unfortunately, with a conventional heart attack, because what happens is the combination of a sort of a perfect storm of cold weather, heavy clothing, the kind of exertion that's involved in shoveling and lifting and throwing the snow, which is often unaccustomed. For most of us don't do that kind of thing very often, and often it's a kind of a prolonged period of shoveling out there. So that process can cause what's called plaque rupture. So the plaque, as you may remember, is the collection of fat and cholesterol in the lining of the artery covered by a cap. And that stress and strain can cause that cap, which was previously smooth and calm, to become either to rupture or to ulcerate, sending that cascade of blood clotting in the heart arteries into blockage of circulation, which is what causes a heart attack. But you can certainly see how it's stressful to shovel, but the classic shoveling related episodes are conventional heart attacks.
Okay, you're popular. We're getting a couple more questions. Is there anything that can cause this condition, even if someone's not going through anything stressful? Have you seen these symptoms without like an event that's stressful?
Yes, it is rarely but possible, rarely described, but possible to have this syndrome without any kind of a precipitating factor or something that you perceive anyway to be a precipitating factor. But people with it typically do not feel well, and so it's all part of the evaluation that a person would receive typically in the emergency department, where you would give your symptoms, you'd have this troponin blood test, you'd have an electrocardiogram, you'd have a chest x-ray. If there were any abnormalities in any of those, it would result in additional evaluation like the echocardiogram, the angiogram, and so the diagnosis could be made that way. And so you would not be asymptomatic with this. You would have symptoms with it, and it is sometimes described in people who scratch their head and say, gee, I didn't have anything that I could clearly point to that brought it on. But that is pretty rare. It is typically in a scenario of stress.
And a question about how is broken heart syndrome treated if a patient has Raynaud's syndrome?
Has what?
Reynolds syndrome?
Oh, Raynaud's. So
Raynaud's, yes.
Raynaud's is a type of sensitivity of the blood vessels that can cause spasms. So there isn't a specific Raynaud's treatment, except that typically you do try to avoid beta blockers when a person has Raynaud's, because they can exacerbate the tendency for blood vessels to spasm. So you could use the other medications, the ACE inhibitors, the diuretics if need be. If someone is having a rapid heartbeat, you could use a calcium channel blocker instead of a beta blocker to slow the heartbeat down, but that doesn't specifically blunt the adrenaline. But the ACE inhibitors also affect the hormones that are involved in this process. So you can still be treated even if you have a reason that you should not be taking beta blockers.
Okay, and one more question. I'm hoping I'm understanding this correctly. What is the different similarity of this syndrome to cardiac syndrome X? Is that?
Yeah, so
Okay.
cardiac syndrome X is a small vessel reactivity. So when we talk about a heart attack, the classic heart attack involves the large blood vessels that go to the heart, like the picture I showed you. But what happens with circulation is you start out with a large blood vessel called an artery, bringing blood to the tissues. Then they divide into smaller ones called arterioles, and eventually you get to capillaries, which is where the exchange of oxygen and nutrients occur. So syndrome X is a poorly defined syndrome in which those small blood vessels are not functioning properly, whether they are not expanding and contracting appropriately to physiologic demand, and it can be associated with chest discomfort that is classic for poor blood flow to the heart muscle in the absence of defined blockages in the big arteries. And this, to my knowledge, there isn't a connection between the two, although small vessel dysfunction is postulated perhaps to be part of the mechanism of this. So the research is ongoing. That's a good question, though.
Interesting. And just, I'm going to do one final question, folks. Do you think it's important for a woman to go to a cardiologist who specializes in women's medicine? How important is that?
Well, I think that, considering what I do and who I am, I do wind up seeing a lot of women who do feel this way. I can tell you that there was a big New York Times article over the weekend in the magazine about menopause, and I can tell you that menopause is not well taught. Was not anyway. I'm not in medical school now, but certainly when I was in medical school, we didn't learn much about it in terms of what people experience. We did learn about hot flashes and some of the things, but there wasn't a lot of time spent. And there is a sort of a reluctance among many people to talk about it. It's embarrassing for women of a certain age, and many people feel like it's a personal failure, the lack, the end of their fertility and other such things. But the more I do this, the more I learn about what that process is like, for women, and what symptoms they may experience and their specific aspects of things. I also take care of many women who are pregnant and having children and having various cardiac complications. And I do think that having personal experience with everything informs how you treat people when they come to see you. There are certainly men who are interested and capable of taking care of such conditions as well. But I do wind up seeing a lot of people for just this reason. And, there are certain people who are, as they're going through their life and are interested in preserving their health as well as they can, who want to come and have the conversation. And what should I do? When should I look for this and other such things? And, I'm certainly happy to do that. So, I've had people come to me and say, "Oh, do you see men too?" And yes, in fact, I do. I see men and women in my practice and always have, but I do see, a lot of women for exactly the reason that the questioner is asking.
It's such a sensitive topic. And I appreciate so much. And a lot of people are saying, just to know a doctor who can be, aware of the mind body, right, and take it seriously, and to be sensitive to it. It's just, these conversations are very difficult. And just real quick, someone was talking about having that experience, losing a child and just having such a tough time. And somebody else said, "Thank you, so informative and helpful." A lot of thank yous. And just one more question: anything to do with inflammation and broken heart syndrome? Any research on that?
Well, that's a great question too. So we know that chronic inflammation, is associated with a higher risk of developing coronary artery disease, and that the myocardial infarction that we discussed earlier. I'm not aware of any particular data linking chronic inflammation with stress cardiomyopathy, but heart attacks are far, 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 far more common than stress cardiomyopathy is. So by its very nature, we know more about heart attacks than this relatively recently described condition. But chronic inflammation is definitely something to be taken seriously in terms of evaluating a person's global cardiac risk.
This has been such a wonderful presentation. Many thank yous from the audience. Thank you from me. I hope there's more and more research on this. It's so important. So
very much so.